guys are gonna get like a checkpoint or something like that. So I agree. All right. So just a brief notes in here. This is Eric. Eric is he's been a coach on the All Star Dental Academy for a few years right now. I think Chris. I think it might be. I don't know, Christopher Figueira or Christopher Young. But anyways, hi Chris. How are you? So Eric is a All Star Dental Academy coach. He's been my coach for. Hi Chris. How are you? For a few years. Also, he's the president of the coaching, so of the coaches of the All Star Dental Academy as well. He holds a degree in business administration, and he has a great verbal skills, which is great for talking with patients and with the staff. Also, he creates some systems for the practice, and he's great on tracker numbers, tracking new patients, tracking old patients, tracking how much the collections, production. So he's great on that. And he has also helped offices moving from insurance-based office to fee-for-service office, and sometimes even decreasing the amount of insurance that you're working with, so you can make sure you can get a better deal and better make a better intelligent choice between which insurance you should keep it and which ones you can get away from, and how you can actually become more fee for service. So Eric, everybody's all yours.
Thank you. I appreciate you having me. I told Dr. Perez, I said, listen, I want to support you in any way I can. And we were masterminding and figured out, you know what? If we help your referring sources, it'll help your practice too. So I'm here just to give you guys information, to share as much knowledge as I can. Larissa, one of my fellow coaches, is joining us too from All Star Dental Academy. I've been coaching offices for 21 years now. My father-in-law is a dentist, so I come by it naturally, although I have a banking background before I got into dentistry. And I love helping practices understand the business side of things. I love helping customer service. Disney World's one of my favorite places. I'll be there in February. So, putting customer service and business aspects together, helping dentists and their teams understand how to grow in a healthy way without pressure, things like that. I really enjoy that. And so our coaching team is built around, what's your vision? Let me help you figure out how to get there, and then point out some roadblocks and give you some pointers if that's right. Today, we're going to talk about insurance free, I guess. But that word is very tricky, insurance free, because there's different levels. So I think, Dr. Perez, I think you said you were going to share a story about your before we started working together, your trek on how you got to a place of being fee for service, right?
Yes. So there's a easier way, I believe, and there's a little bit interesting way, the way that actually I did, which is a kind of not that great, because pretty much I woke up one day and I say, something, I cannot be working with insurance anymore from one day to another, because my July month was so slow in 2018. And I say, the patients actually were coming in and doing treatment, and were actually patients without insurance. So the patients that actually were falling through treatment and actually accepting the treatment was actually the patients out of network anyways. So that's why I say, that's why I learned that you have to send letters before about 90 days, but you have to let the patient know what's going on, everything else. But there's a nicer way how to tell the patient in a nice way why, especially explain to the patient why you're getting out of network on the insurance such. Sure. And then it's easier when the patient read the notes, receive the letter, and then you actually explain the patient when they gets here.
Yeah, there's no surprises that way.
And then, oh, surprise. Or just give a nice letter, we are out of network. So great, we are out of network, but what does that mean? And that's why Eric comes along and helps quite a lot.
Absolutely agree. Yeah, I think just as a cautionary tale, if you're considering, removing yourself from a insurance-based practice to go into some sort of different category, sending a letter is probably a death sentence for a practice. It can be done, but it's not the way we recommend it. So we have to make sure that the business is in a position to be free of restrictive insurance in a healthy position before you do that. And that's the things that we do as coaches to make sure, hey, this is actually a smart business decision for you because you meet these standards, you check these boxes. We'll have some clients where we'll say, you know what, I would not recommend that you do that right now. And I'll get into that. The first thing I want us to get clear on, because I think sometimes there's some confusion here, is what does in-network mean? Participating with insurance. What is out of network, and what is fee for service? And those are three different levels. And so, if you're in network, you'll see the numbers. I have some examples. So if you are in network with insurances, the typical average rate, let's say you're charging for something $100. The typical average rate of write-off is around 42%. So in network means you charge $100 for something, insurance says, no, you got to write off $42, 42%. And this is what you're going to collect down here. 58, patient's going to pay nothing. Let's say it's preventive. Okay, that's in network, just to create some definitions. Now you decide to go out of network with insurance, means you charge $100 for that same thing. There's no write-off required. And the insurance pays you $100 and the patient pays nothing for that preventive service. The interesting fact is 95% of insurance plans are written with in-network and out-of-network benefits that match as long as your usual and customary fee is within the normal limits of things. If you want to go charge $300 for a pro fee, of course, you're not going to get $300 for that. But if you're going to charge $120 for a pro fee, 95% of insurances are going to pay that. And so a lot of offices don't understand that going out of network from in-network, low fee, to out of network, $100, can be done and done pretty simply. And the math goes like this. If you're writing off 42%, you can afford to lose 42% of those patients when you go out of network and still break even, as long as you have the insulators, enough patients in place to do this. We never lose that many. We lose 5 to 10% of your patients in this process when it's done properly. So fee for service is a whole nother ballgame. Like Dr. Paris, when you're fee for service, that means the patient pays you the $100. We bill the insurance for them and they get reimbursed $100 indirectly. Now, as long as that's not the big one in the room, right? D, we know who we're talking about here. I won't use specific names, just so I don't want to get in trouble with any specific insurances. But there is an insurance company out there, a big one, where not all the time will the check, if you're out of network, will the check come to you. And that's a whole different conversation we have to have with practices. So when we deal with the D insurance company, we have a specific way of doing that and helping insurance. I'm going to show you an example of that. Actually, a client we helped resign from that insurance plan specifically. But before we deal with that one, we deal with all the other insurances first, and we help you get out of network with them. And then fee for service would be a secondary process where patients are paying you if you want. That's a choice to make. You don't have to make that choice. You can still be free of restrictive insurance and just be out of network. Does that make sense to everybody? Okay. All right. I'm seeing nods of heads. Yes. Okay, great. And I speak to dental schools often, and often I'll hear dental students, when I explain that, they'll say, wait a second, you can be out of network with the insurance and the check will still come to you? Yes, except for two insurances out there, right? The check will still come to you. And so many of you have insurances that you're out of network with, and the check comes to you. The Aetna, MetLife, Cigna, Guardian, Humana, all of these insurance companies, they will pay you directly when you're out of network. And 95% of those plans are written to pay you UCR. Okay. Makes sense so far? We're good. All right. So I want to show you the process of how we do this, how we take a client through this to make a business decision on it. So I'm going to share my screen and I'm going to mute most of you. So if you want to say something, a question, you'll have to unmute yourself to jump in, just because we're recording it. All right. So let's do it this way. I want to show you the first step we take. All right. The first step we take is by analyzing what plans you're in with. So I just started working with this client in August, and I had his administrative team run reports out of their software. They have Dentrix to tell me all the plans that they are in network with and how many patients they have in those networks. Okay. Now you can see I put in red certain insurance companies that will not send the check directly to the office. That would be Delta, Blue Cross Blue Shield, right? And here's another Delta down here. So in his practice, his software lies to him and tells him he has 2,400 active patients, of which 1,900 of them are in network with something. The awakening for him was these ones that aren't highlighted. He goes, why? How come I'm in with them? I never signed a contract with them. I never got a network with them. What's happening? Well, what happens is when you get in these, you sign a contract with some of these companies. In the contract, it says anybody we lease the plan out to, you will be in network with them as well. So unbeknownst to him, he started getting more and more insurance companies that he was, quote, in network with, which was discounting his fee. Okay. So what we do is we take this information, we go, okay, now we know when we look at MetLife, how many patients we're talking about, 9% of your practice. And the percentage is what we're really looking for, not necessarily the 200.
Eric, just one quick
Please.
question.
Yeah.
You mentioned that the software is lying to him about the new
Yes.
patient. Now,
Yep.
I don't want to forget the reason why you said that.
Yes,
So
good. Thank
why?
you. Because I know that he only has 6 days a week of hygiene. It's the numeric is 200 patients for every 1 day of hygiene that you actually have. So he has 6 days a week. If he had 8 days a week of hygiene, he'd have 1,600 patients. So your software, over the years has collected patients that no longer see you, that haven't seen you in the last 18 months. We all know this. And so it's an inflated number. Because that is inflated, so is this number. This number is also inflated. And I was just getting ready to say, so I'm not too worried about the number of patients as I am paying attention to the percentage, because the percentage is what we're looking for. And what I do with them as we sit down and map this out, I say, okay, here's the plans that I know we can get away with. And you see, I wrote this 25 right here. The green percentage of his practice is about 25% of his practice. No matter what this number is, 24, 1,600, doesn't matter to me. About 25% of his practice is in green in these plans when you add them all up. Okay. Now, what our rule of thumb is, we will never have you tackle more than about 25% of your practice at a time. You would never resign from all of these insurances at the same time. That would be a death sentence. You would never send a letter to all of these people. That is a huge death sentence. Do not do that. You may get away with it, but you may not. For the last 21 years, I've helped offices get off all of these insurance plans, all of them. I've had one in Nebraska re-sign up out of all those clients I've worked with. Over 100 clients I've helped resign from insurance. One of them re-signed up with one plan. He was in Nebraska, in Lincoln, Nebraska. And if you ever look at the address for where you send this claim, it's in Lincoln, Nebraska. And it was a very, very, very big percentage of his practice. And we knew it was going to be risky, and he decided to re-sign up after about 6 months. That's the only one, and I've learned from that one. That was about 7 years ago. I've learned from that one, and there's some different things you can put in place. And in fact, Dr. Paris and I have been talking about this, membership plans. A lot of you probably already have membership plans. I'm going to talk about that later. What we do is we create a tab for every single one of these plans, and I won't show them to you because there's patient names on it. But it has a list of every single one of those 74 patients under Aetna. Okay, the 12 Emeritus, if you go to Emeritus, has 12 patients. You know who they are. And the goal is for us to tackle 25% at a time, but which ones? Which ones make the most sense? You can see I've already created phases for this. The reason this is yellow is because I have no idea if they're going to pay him or not for those 4 patients, and we're going to figure that out. The rest is just green and red. It's just a phase 1, phase 2 for him. And it's going to be a 13-month process. Now, what we had to do is we had to go, okay, we'll just pick Cigna. Wait, what was the 8%? Yeah, MetLife. What is that really costing? You look at a lot of these, a lot of little plans. Like, why are we even in network with these? What's the point of having Physicians Mutual at 1 patient, right? What's the point of being network there? If you're going to write off 42%, you're going to pay money. You're paying to a marketing company to send you patients. It's going to cost me 42% to pay this marketing company to better send me patients. That's not working out for you. So why bother being a network? If that was a marketing company that you're paying, you'd fire them. So let's take, for example, MetLife. Phase 2 of this research is we use what's called a PPO write-off calculator. And you can see we take your office fee and then we put in that insurance company's fee schedule that you have in your office, and we just come up with a difference. And you can see in this office, Emeritus is costing him 47%. Now, the interesting thing is, this was before, when I first reached him, he didn't have his fees healthy. I went and did a fee analysis for him, and we looked at his fees, which we, oops, that's not the right one, which we do for each office, okay? And we actually look at what percentile, this was for St. Louis area, and what percentile, and you go down here, look at a cleaning, let's say, should your fee be? Now, we believe for high quality dentists, it should be in that 70 to 80th percentile range, right here. Well, when I asked him what his fee was for a pro fee, and the last time he raised it, he hadn't raised his fee in about 8 years, and his fee was $93 or something like that. So his write-off didn't look that bad because his fee wasn't healthy. So the first thing we do is make sure we do a fee analysis for you. Okay, now, once we go in here and do a fee analysis, put things in, it might change this percentage, but you look at it 47%. I think we were going to look at some of these other ones. Here's his fee, $92. Well, of course his fee is only 15%, write-off fee is only 15%. His fee is too low for his neck of the woods. Periodontal maintenance. You can see how I changed that, went from 92 and 125 to 104 and 190. And 104 was a minimal increase because I didn't want to increase it too much. But here's the funny thing. When he's at a network with Emeritus, they're going to pay 104. They're going to pay that fee. So I think we wanted to look at MetLife. Let's see if that's on here. Yeah, right here. So it was 9% of his practice. Again, this is a very low fee in his office, and his average write-off was 43%. So when you look at this and you go, man, my overhead model, I might be profitable at 60%, maybe 70%, maybe 75%. In other words, I have an overhead of 75% and then I become profitable. Well, in his practice, he's paying patients to come see him for that hour. He's losing money in that conversation. It becomes a business decision. We go back and we look at it and say, okay, it's costing you 45% for 218 patients. If it's costing you 45% for these patients, when we go through this process and help you resign, you would have to lose 45% of these patients just to be a break-even equation. Never happens. Never happens. Why? Because when you resign from MetLife through a process of communicating to your patients the right way over 6 months, they're not surprised. And we have lots of tricks and trades and hacks that make sure that it's a successful transition. You're going to lose, let's say you lost, worst case scenario, 10%. You're going to lose 22 patients to get paid 45% more for 200 of them. Anybody would do that deal. The question now becomes, really, why am I a network? Which we're going to talk about. Why am I a network? What is the benefit from that? And I want to show you some historic changes that we've made. Okay, so let's look at, let's see who I got here. Oh, so this is that practice that I was just talking about. And what happens is he's not doing a big write-off for his, this is a tracker we put in practice. So Larissa's here, one of my coaches that I work with, and he doesn't do a lot of insurance write-offs necessarily. I want to show you, right? He doesn't do a lot of write-offs, but what happens is his production per patient, he's billing the insurance fee in his ledger. So he's not doing a bunch of insurance write-offs. So what happens is his production hits a ceiling. He can't get over 150 an hour. Now, depending on the area you live in, 150 is the absolute minimum just to cover costs in your hygiene department. 175 now, as you guys know, people are asking for raises. 175 now per patient is becoming the BAM, the bare minimum that we want to have on that number. That's in hygiene. And also what's happening to him, he's not able to get to the 500 per patient number because insurance fees are keeping it held back. You can also see in this practice, I can't see up here. I got to see who this is real quick. Oh,
Eric,
okay.
I'm going to bother again.
Please go
Question,
anytime. Yeah.
You mentioned about the 150 to the 175. in hygiene, how do you calculate that one? It's just based the collection or production of hygiene divided by the amount of new patients?
Yep.
You
Yeah,
use
so-
collection or production?
Okay. Depends on the practice. Everybody does it a little different. So that's what I was saying. In his practice, he bills the insurance fee and doesn't do a write-off over here in this column. These are our write-offs over here in our tracker. And so we just take his total production.
That was hygiene, the 33.
Yep. Hygiene for his hygiene department, 2 hygienists being seen. I got to see who this is. I got to make sure I'm talking right. Yeah, this is in Utah, different practice than I was just showing the fees. And so I started working with this practice in 2019, and I'll show you the difference. So what's happening with this practice is they're still being held way back because of insurance. I'm going to show you a difference of before and after. But we just take total patients, total hours, and divide that by production, and we get an hourly and a per patient.
Okay.
Now, what's funny about this practice, if you go back, this is 3 years ago when I started working with them. Look at what their production per patient was then, 120. Okay. And it's because, and look at what he was collecting. Look at the average. This is before we helped him resign from insurance. He collected $76,000 a month. Didn't change any providers. Okay. Now monthly collections are at $108,000. So we resigned from insurance and grew his practice $31,000 a month. Larissa, I think that's well worth our monthly coaching fee. I'm just kidding. So, I mean, we see it all the time. I will show you another example real quick. Let's see. This is an example of, and I think I already have one of these pulled up. I want to pull up 2. This is the practice I was just showing you the fees. Because of insurance, right? He's only producing 101 per patient. He's not even getting the 150. Remember I was saying his fees are too low? Not only is fees too low, but he's writing off 42% of that. He's not profitable. He's not getting to that 150. And I just started working, like I said, a few months ago. So we look at back months, but I have 3 months of data now where I can say, Dr. S, your hygiene department is failing. Here's his doctor department. He's not even anywhere near 500 per patient. We know that is the industry norm to cover our costs, let alone with inflation this year. Those numbers are rising. So I want to show you a different example. This is the one we did recently with resigning from the big one in the room, the insurance D. So this was a very successful practice already, but you can see he was writing off, $41,000 a month. He was only participating with one insurance. It was 63% of his practice. Now, earlier I said, I don't mess with more than 25% of your practice. And he's a client of mine. He says, Eric, he's in Michigan. He says, I got to get out of this. I want to add an associate. If I add an associate, they cannot be premier like I am. They have to be PPO. I did not want that. And he was nervous because the number of Delta was growing. Now I show you this. I want you to pay attention to 2 numbers. In March 15th, we resigned from that insurance company. This is from last year. This is 2021. He was writing off $41,000 a month and he was collecting $160 a month. Pretty good practice. It's a big practice. 4 hygienists though. 1 doctor working way too hard. Okay. Writing off 40, collecting 160. Now you go to this year, March 15th, you'll see similar numbers. You'll see how this works. January, February, still writing off the 45,000, right? A month. March 15th, half of that, that's when we resign. He went from collecting 160 a month to collecting 234,000 a month. Check going to the patient, patients paying UCR in full at the time of service. Why? Because way back when we started the process with the patients, we started communicating with them, we took our time, we had patience in it, and we made it did it the right way. His write-off rate was 42% with insurance company D. He would have had to have lost 42% of his patients for this to break even, just to collect the same amount. Here's the crazy part. He had a hygienist leave. She was moving away. He went from 450 hours in hygiene, right? You see these 3 months right here. He went from 460 hours a month down to 360 hours a month. He went from producing 89,000 a month in hygiene down to producing 61,000, and his collections went up. Remember I told you he wanted to add an associate? So he went from a doctor producing, 161,000 to producing 107, not much of an increase. He just took more time off. He's getting a lunch now. He's working smarter, not harder, all in the favor of fairness. Okay. So I've rattled off a lot of numbers here. I've given you a lot of data, and I want to give you a chance to ask me questions about that before we go into the next part of this conversation. And the first thing I'll just summarize is this. You need to know the percentage of your practice that has insurance plans and how many patients in each one. Then you need to know how much percentage of write-off you're doing in each one of those plans. So we can figure out a plan on who we're targeting first, which insurance companies you can resign from first. Does that make sense? Okay, questions so far? Oh, Dr. Melendez, you were asking some, but any other questions for me? Numbers are making sense of what I'm sharing with you? And Larissa and I, we have examples and examples and examples like this that we can show you. I don't want to bog you down with data. Okay, so now let me say this. I have offices, they'll go to resign. I have another office in Nebraska, and she's been resigning, Dr. H, she's been resigning from insurances for the last, year and a half with me. And she went to resign from an insurance company, and they said, you know what? You're our only one in network, and we really want to keep you. We want to keep you in network. We're going to guarantee that we're always 10%, just 10% write-off rate, 10% less than your UCR fee. And we're going to give you a sign-on bonus. And she's like, I want to do it, Eric. And I said, okay, do it. Let's see if they do it. It's been a while. We're waiting. We're still waiting for that fee to kick in. She's in for a year now, I think, or a year or 2 years. She had to sign a contract that should be a year because she cashed a check. They sent her a bonus. So she's in now. This is with an insurance company. It starts with A. And I still haven't seen the 10% fee comparison. I do have some insurances, some offices that they show them the fee and they only sign on when they have that fee schedule and they're in. They were never in and they got that. Now you might decide that that works for you. I have a doctor I worked with in Maine who the insurance company, when he said I was resigning, they said, we will match your fee if you stay in. This was about 45% of his practice. It's insurance company D. Never heard of this before. They said, we will match your fee if you stay in network. And he still said no, which was surprising to me. This is about 6 years ago. And I said, last name starts with D. I said, Dr. D. I said, why? Oh, no, Dr. P. First name starts with a D. So I said, Dr. P, why would you not agree to that? Why would you not say, I will stay in network, get your fee? And he said, because it's about dentistry. It's not about me. The next dentist that comes along is not going to get that deal. And I'm not going to do that to the next person in line who's going to have to take less because I took this deal. If we're all out, everybody wins. But as soon as I'm in, they got to be in too. And it creates a challenge. Side note, his son was in dental school. So he's talking about the next dentist coming along, right? And so he didn't want to do that to any of not only his son, but to any other dentist. And that was a philosophical decision that he made. Not my choice, it's the client's choice. So there may be some plans that you want to be in network with, and that's your call. But I want to challenge the thought process and say, okay, what does it look like on the other side? 50% of dentists, forget about insurance plan D. 50% of dentists are out of network in Love and Life. They're not going back in. You put insurance plan D in that mix, it's a totally different statistic. We have never received more phone calls in the last 18 months to help offices resign from insurance. Then in 20 years I've been doing it, the last 18 months have been crazy. COVID did something. It created a backlog. It created an influx. It put those natural insulators where you're so busy. You look at your schedule going, why would I be in network if I'm this busy? And started opening that and going, inflation, what's happening right now? I can't afford to give the raises I want to give my employees. And so it started changing the game for us and waking us up a bit. So wherever you are on the spectrum of that, philosophically, we can look at the numbers and help you make a decision as to is it a good decision for you or not? I will tell offices, depending on who you're in network, I'm working with an office right now. He wants to resign from a big insurance company D, and I'm hesitant. I'm showing him pros and cons of what could happen or not happen. And are you sure you want to do this? I work with another client, Dr. S in North Carolina, and I show him these numbers, and these are like no brainers. I'm going, let's get out of these plans. And he goes, I just want to do one at a time. And it's 5% of his practice. I go, Dr. S, if you lose 15% of these patients and you resign from this insurance company, you're not going to feel anything different financially. It's not enough. You need to at least deal with 15% of your practice at a time to make it worth all the effort you're putting into this. If you're going to lose 15% of those patients, then the 85% who stay have to have an impact in your bottom line. You're putting work in. They're a little more fearful, which I understand. And so we're going to take baby steps, and that's okay. That's his call. All right. Any other questions for me? All right. We'll do some Q&A at the end too. So I want to be careful how I say this, but if you haven't done a fee increase this year, if you haven't done a fee increase, maybe you did one this year, but you haven't done a fee increase in 6 years or 4 years, I hear this all the time. That's a huge concern. And we are happy to supply you with a fee analysis. It's like 17 pages, shows you all the percentiles of where you ought to be for your zip code. We believe in about the 70 to 80th percentile. If you're not doing a fee increase, I want to talk to you about why. I want to understand why before I just say you have to do one. But I want to understand, maybe your fees were already way up here or something. I want to understand. But that is number one. Number two is I want to talk to you guys about membership plans. I think membership plans create a huge advantage. Raise your hand if you already have a membership plan in your practice. I just want to see if anybody has one. Okay, Pamela. All right.
When you said a membership plan, like an in-house plan?
Savings plan, in-house savings plan?
Yeah, we do have one.
Okay. All right, great. So thumbs up, that's working good for you guys?
Yeah.
Yeah. Okay. All right. See nodding of heads. Membership plans are amazing in this process as well. And I would recommend that you have one in place beforehand. And we recommend Denvantage would be a company that we recommend. They're dentist owned, and they've been clients and friends of mine for 20 years. They practice, they use it in their practice. And then there's another company called Clear, Kleer, great company as well. So the other thing is a monthly membership plan helps much better than an annual priced membership. And I won't get into the details of all that, but that's one of the insulators we make sure you have in place. If any of you are saying, I am not making the annual income I thought I should have been making at this point as a dentist, if you're not able to pay your employees what you want to pay your employees, if your supply bill is going up and you're feeling the pinch of that, if it's coming out of your pocket, then, and you're in network with these insurances, this is something to evaluate. It's something for us to look at and say, well, does it make sense that you're in or not? And it takes a little time to do, but it's well worth it if on the other end of it, you can, get a fair deal on this, whether that's 42% or even just 20%. If half your practice is insurance based and you're right now 42%, that would be a 20% increase in the change. So if you're an $800,000 practice, all of a sudden overnight you become $1 million practice, and now you have some breathing room to pay your employees more, to pay those lab bills, to pay yourself. At the end of the day, this is a business, and the good news is we're in the business of taking care of people and getting them healthier. I want to make sure that we stay, as solo practitioners, we stay healthy in that we know how to run our business, that we understand the business, the ins and outs of running a business in a healthy way, knowing what your profit and loss percentages should be. Is your payroll less than 26%? Is your lab bill 9%? Is your rent less than 4%? These are things that we evaluate and make sure that we look at and go, hey, you're really healthy. Do you want to do this? And if so, why? Let's dig deeper into it. Okay, membership plans, overhead. And then it becomes a 6-month process. Now, this is where coaching really comes into play, because your employees have to be trained on this, and you as a doctor have to be trained on this. So there's a systematic approach we use to every day at Morning Huddle. Your team has identified which patients are on that list for you and which you're going to have conversations with. Another reason why you don't try to talk to 60% of your patients. Dr. K up in Michigan, 63% of his patients all at once. That was one plan. That meant 6 out of 10 patients he was having a conversation with every single day for 6 months. It was a lot. There's a lot of prep that goes into it. Now, depending on what insurance that you're looking at will depend on the conversation, but you're going to have an effective conversation about how you're going to handle things in the future. And we go through hours of training with you on what to say versus what not to say. So I'm not obviously going to spend a lot of time on that with you, but I'll tell you some things you don't do. Don't tell them what you're going to not do anymore. All right, we're no longer going to take your insurance, or we're resigning from your insurance plan. Okay, we're going to drop this insurance. These are key words that tell the patient, I no longer can be your patient. Why? Because insurance, when they think of insurance, do patients think of medical insurance? Let's say they're not in your office. Do they think of medical insurance or think of dental insurance? They think of medical insurance. That's what stands out to them more. And when a medical insurance plan, when you hear out of network and you have medical insurance and your medical provider says we are out of network providers, that means you no longer can get any benefits at that provider. So immediately, if you say out of network to your patient, they associate that with medical, put the same label on dental and think, oh, I can't come to see you anymore. That's why sending a letter says, I will no longer be in network with your insurance. I will now be an out of network provider. They go, oh, I can't go see this person anymore. And they leave. But if you have a one-on-one conversation with this patient, explaining this to them in a very simple way, you will see retention on the other side of this. We know that if you say the right thing, you will see that 10 to 15% less atrophy. You will see the results of those numbers I showed you with Dr. C in Utah, Dr. K in Michigan, and we're getting ready to help Dr. S in Missouri. So sit down with every morning at morning huddle, 15 to 25% of your practice at a time, and your team members telling you which patients you, the doctor, are going to have a conversation with that day in hygiene. For 6 months, you're going to have that conversation. And depending on the insurance will depend on the conversation, but it's what you're going to do, not what you're not going to do anymore. Okay. Now, has anybody already gone through this process and done it successfully? Like you had a good experience with this, you resigned from insurance and you've done this well in your practice? Yeah, Dr. Pires, yes, you've done it. You kind of learned the hard way, but you got there, right? Yep. Okay.
Well, I think, Eric, also there's a lot to do with culture of the practice and the patient experience. Because in my office, we did accept Delta at some point. And that was the only patient insurance that we were like in network. And we did it just to try insurances because we started in 2009 as an out-of-network office, and more offices were opening in the area. We noticed a little bit of a down spiral in the new patients. So we decided, okay, let's try Delta. And the D plan. So we tried the D plan and we were doing fine. And we were planning to just relocate to a new building, and we wanted to have a fresh start. And we decided to just start dropping the insurance. And it was hard because out of a sudden we end up losing a good amount of patients. But you know what? Our patient experience, I think, was what we try to cater for and create such a pleasant environment for the patients that some of those patients that they just come back because they go to any network office and they don't get treated the same way. And even though they have to pay maybe a little bit more, like a premium price, they see the value.
That's right.
It's not the same get a cleaning in 15, 20 minutes versus having your hygienist spending 45 to an hour with them.
That's right.
And they value that kind of service. So I don't think if anybody's trying to drop off insurances, I think, like you said, should get prepared first.
Yeah.
But create such an environment that the patient goes somewhere else and they don't feel the same,
That's
they
right.
come back to you.
That's right. When you walk into Walmart, it feels different than you walk into Nordstrom's. And
Absolutely.
So what we call this system that Carlos is talking about, we call it, why are they married to you? Why are they married to you? And we have you do hey, be a patient in your practice. What's it like to be a patient in your practice? Why are patients married to us? Do they marry us for the money? It's cheap to come here. Do they marry us for the money, or do they marry us for the experience and the relationship that we have? Is it transactional or is it relational? And you look at ways to bridge that gap before you resign to say, okay, we need to be more relational with our patients. What are the things we have to do? We have to bite the bullet and go to 1 hour hygiene visits for adults. We have to create an experience for them that is not rush, that feels like quality, that feels like relationship and time spent with them. Absolutely. Because when the money changes, the relationship changes, if that's why they married you. It's like the movies, right? When they get married, you know, one of them was marrying the other one just for money, and then they lose the money. It's like, oh, please fall in love. Please still be in love, you know? So that's why we call it, why did they marry you? Second thing you brought up was really, really good. And you say dropping, but we'll say dropping here, but with patients, we don't use that terminology because they think, oh, you're dropping me. So we helped an office in the Bay Area in California, where I'm at. I'm in California. And Larissa's in, are you in New Jersey, Larissa, New York? Where are you at? New Jersey? Yeah. So we helped this office resign from a D insurance plan in 2015. And we did it right. We did it really well. But the practice was about 55% in this plan. Very, very big. We lost 60% of those patients. It was a 2-doctor practice. Seems catastrophic. Seems like doors closing when you hear that number. That means they lost what, 36% of their active patient base as a whole? The next year, they collected the same amount of money that they collected the year before. It was a wash. Now, what Dr. Melendez is pointing out, they get 32 new patients a month in their tracker, and 16 of them, about half of them every month, have that same insurance plan, D insurance plan. Because those patients don't know any different. They're new patients coming to them. Oh, this is how you always done it. Oh, I pay you and the insurance reimburses me. Oh, okay. They don't know any different. It's the patient, and some of those patients came back, right? The 60% we lost. Practices are growing, doing phenomenally, completely out of network. Okay. Now, I will also do just a cautionary tale here on insulators. What Dr. Melendez, you move and you make a change. We don't recommend you make 2 big changes at once. Like, I would never recommend you buy a practice, right? Buy a new practice and then boom, make a change. Wait, who's this new guy telling me all this stuff's different? If you're going to switch it on me anyway, I might as well go somewhere else. Oh, and you're going to tell me you don't take my insurance? I'm going somewhere else. So we do 1 change at a time. Give them 2 visits in your practice before you make a second change. Let them build in that relationship with you. Let them build in that connection. Oh, I really like this new doctor. This is great. Oh, I can see why you guys are doing that. Yeah, inflation and all the stuff, right? Is this making sense, guys? Okay. So now it becomes conversational. It becomes relational. This is how you engage with your patients. So it's a 6-month process. It's not easy. The whole team has to be on board. They have to understand the numbers. And the last thing I want for you is for team members coming to you and say, hey, I want to raise. And you go, I don't have it. Or you saying, hey, let's resign from insurance. And team members going, yeah, I don't really feel like that's a good idea. I don't really want to raise fees. I don't really want to, make the patient uncomfortable. Oh, but by the way, can I get a raise? Can't have both, right? Cake and eat it too. If we're going to do this, if we're going to grow and you're going to have expensive equipment that takes care of your patients, we do this with endodontic offices. We helped an office in Rochester, not New York, Rochester, Minnesota, and 2 endodontists. And Dr. Pierce knows him. He's in our mastermind group. And we did this this year, January 1st. And it's a good practice. They're collecting $40,000 more a month now, resigning from 1 insurance plan, which was insurance plan D. But the team had to love the idea. They're the ones having the conversations. You can't have people who aren't on board with this, wondering why you're doing this, and you haven't explained the vision in a way that's clear. This is where coaches come into play, help them really see the light on this. If you just walk in as a doctor and say, all right, we're starting a 6-month plan on how to resign from insurance. And here you go. And they don't get it, then they're going to drag their heels and you're not going to have a great experience.
Well, one thing that it's really important to figure out, it's before I started working with Eric and everybody else, I was in with maybe 20, 25 insurance when I bought this practice in 2015. So I started cutting down slowly, not completely at once, but slowly, maybe 5 insurance for maybe every 3 months or 6 months, see how the office. One thing I figured out, I started opening my schedule, which freaked me out. But at the same time, I was making the same amount of collection and not worry about, I'm doing more production and collection just coming up like 6 weeks down the road. Actually, it was having the collection coming first before my production. So right now I have like problems because some of my patients, they already pay off for the entire treatment, but I have just done part of it.
Yeah, they
So
have a
because
credit. They have a
my
credit
collection
on
went
their
up,
account. Yeah.
and I'm working less. So
Yeah.
I see more space in my schedule. So it's more psychological problem in our
Yeah.
end as a doctors, because we are so used to get full schedule all day long. We're
Butts
gonna
and
see,
seats. Yeah.
yes, we're gonna see more space here, but at the same time, we're gonna be more productive in that time than actually entire day.
So here's what Dr. G, our friend, said up in Rochester. He told his associate, she wasn't sure about this, how to get on board. I wrote it down here as you were talking, Carlos. You triggered something. He said to his associate, I'm doing 8 root canals a day, and I'm getting paid for 5. Why wouldn't I just do 6 root canals a day and get paid for 6? And this is what we're talking about here. Why are we killing ourselves to get this much? We could just do this much and make that much. We'll still make more. We'll still be more profitable. We'll still have more money at the end of the month if you do it right. If you do it right. So good. Larissa, anybody else want to add anything to this? Anything, any questions, suggestions, things that you've done that have worked? I would love to hear that.
Oh, you're the master. So I just agree with everything. No, really, I've gone through this process with other offices too. And, Dr. Paris just said something, it is psychological. When you see an opening on your schedule, I know, we don't like to see that, but you have to work smarter, not harder. So that's what the process, helps out with.
Amen to that. Yeah, it is. I'm so glad that you're echoing that. And when you look at the numbers, jump in.
The other thing with fee for service, like again, Carlos and myself were like very close to each other, is that when what he was describing, usually in a healthy profit and loss, you'll see the collection and production very similar. That's how you want your year to end. But what I tell my team is like, if you see that the collection starting to just be a little higher than the production, we have to start getting those patients' asses in the chair.
Butts and seats.
Because then what happened is that if they're already prepaid, which we try that as much as we can, because I don't want, especially I work also every other Saturday, and when the Saturday is nice and shiny, you want that patient to be in the chair, not at the pool, not at the beach. So they usually get prepaid, but you don't want those patients to get like buyer's remorse. So if the collection is off for 10, 12, 15,000, we have to get the treatment done right away.
Get them in.
Otherwise you get refunds. And the other way, if you see the production higher than your collection, that means that you're not closing your cases.
And that's fee for service.
That's fee for service. It's challenging, it's doable, but it's kind of challenging as well, and you want to make sure with your team, like I tell the girls sometimes, there's something that I learned with another consultant, MGE, that something called fair exchange. If the patient is paying you, let's say $5,000 for a treatment, you want to make sure that day you give something in exchange. Either you schedule all the appointments and give them all the appointments for their necessary treatment. Either you start a filling, either you take some impressions for like study models, something that they feel that they are taken care of already. Otherwise, they go home and they start, I spent like $5,000 and didn't get anything, So that's my only
return on investment. It's ROI, and there's an emotional attachment to that. Absolutely. Post-buyer remorse. They pay you money. You've done this. You've bought a big car. You made a big purchase, and you've walked out, and that night trying to go to sleep, something's off. It's called buyer's remorse. It's a real thing. And so you have to provide them something they go, oh, that felt good. I really like that. That's a good decision on my part. It's encouragement. Stay connected with them. Now, what Carlos is talking about is fee for service. That's the next step for this. First, it's being out of network. Then it's fee for service. And with insurance company D, you would have to be that if you're out of network with them. That's the only one you're looking at. That's a different conversation that we have with the patient, because they got to expect to pay when they come in next time, if you're not going to have them prepay for like a hygiene visit. So I'm curious, Dr. Melendez, for hygiene, how do you handle a 6-month visit? Do they prepay for that, or do they just pay that when they come in that day?
They we have everything. We have a little bit of everything. We make sure that the patient leave the office with their appointment already scheduled.
Yep.
Right now I came up with idea before the end of the year, like for loyalty programs, like come up with like if you prepay before the end of the year, you get like X amount of discount for next year. But we try to make it as comfortable and easy for the patient. Try not to put any stops and barriers. Cater their time. We have also extended hours some days for patients that they don't have the luxury of time during the regular hours. And every other Saturday we just open as well. So we use that as a catch. Hey, if you cannot come X day, we offer you like these other days. For sure, every single appointment at my office, we try not that much hygiene, because hygiene, is more flexible. But for treatment, all the patients get prepaid.
Yep.
It could be for a single filling.
That's it.
Because that guarantees that
they're going to be there.
They're going to come. The car is running. They don't have a flat tire. The cat is healthy.
Didn't get run over.
You get a little bit of everything when it comes to these appointments.
These insulators, I love hearing what you're saying. So you're actually talking about a business term called friction. So Dr. Pires and I worked on this. Larissa works with her clients on this. Friction is a real term. It's a business term. And the visual with Zoom now is like this versus smooth like this. So friction is anything we do in business that makes it difficult for someone to do business with us. About 7 years ago, there was a company that came on the scene and said, you know what? For $99 a year, we'll ship everything to your house for free. And people went, oh my gosh, I'll just go down the store and get it. Now, 80% of the people are paying $139 a month to have something show up their door every other day. Okay. So it's how you present that. Now you could buy anything there. Well, I'm not going to buy a book or a DVD. I could buy anything with that company. We all know who I'm talking about. So you have to present it to your patient. You have to frame it. We teach this. We didn't invent it, neuro-linguistic programming. It's been around forever, but you frame how you communicate to people. You leave out what doesn't make sense to them and you focus on what does, so that the perception that friction is being removed. You're never going to get rid of the friction that you're only open 8 to 5 Monday through Thursday, if that's what you're doing. You can do like what Carlos is talking about. You're never going to get rid of, I'm afraid of the dentist, until they have an experience with you. You're never going to get rid of, oh, I don't have insurance, I don't think I can afford it. Oh, it's expensive, it's painful. These are frictions that we deal with in dentistry. What you can get rid of is the perception that those are such a big deal. Oh, it's only $139 a month, and you get Amazon Prime for free, and you get it, right? You have to be able to communicate with your patients effectively to remove the perception that the friction is such a big deal that's a barrier to doing business with you, especially if you're resigning from insurance. So that conversation, I know that I'm holding back some information from you guys tonight, because if I give you something, you're going to be just dangerous enough to go make a mistake. It really takes a specific amount of training with your team to have a communication that's effective with your patient. And we would be happy to help you out with that. Eric at allstardentalacademy.com, Larissa at allstardentalacademy.com. I would recommend that you go to All-Star Dental. Dr. Pires is a client of ours. He's an All-Star member of that. There's virtual training on there for hours and hours and hours of your employees. One of the insulators we talk about is, if you don't know how to handle this, you're not going to be able to get to there. So All-Star Dental Academy is amazing at having an onboarding process, an online training dashboard that shows you how to train your admin team members and your clinical team members on new patient call, stopping cancellations, ideal day scheduling, customer service. And then as coaches, we get into case presentation, practice analysis, KPIs, growth coaching, high performance coaching, you name it, and how to resign from restrictive insurance. So do me a favor, check out allstardentalacademy.com and email Heather, my business partner. Heather Nottingham and Alex Nottingham founded All-Star. And you can just email Heather and talk to her about things. She'd be happy just to tell you about it, just meet with you and give you more information. She's phenomenal. She's a great trainer and she kicks butt. She's a stick of dynamite in a little tiny firecracker package. So Heather at allstardentalacademy.com. So more questions. What else? I could just start calling on people, I guess. Or good ideas, things that you've done that have worked, that have changed your practice. This is the mastermind, right? I love great ideas. I steal them all the time.
So like Carlos said, you need to have a nice culture in your office.
Mm-hmm.
Everybody needs to be on board. You have to show like a patient appreciation. So, the patient likes, because they just gonna go for the treatment if they like you, first of all. So for a general dentist, it's a little bit easier because you're gonna see the patient over and over again. On my hands, a little bit tougher for any specialist because we're just gonna see the patient for that, and most of the time the patient's gone. So if you send a patient for a gum graft, for me, I'm gonna do my gum graft. Usually the patient's gone. You're gonna send to me for frenectomy, so it's a little bit harder for a specialist to get the nice environment for the patient, but you still get it. For a parent patient, it's completely different because we pretty much should get married with the parent patient anyways for the rest of our life, because every 3 months we're seeing the patient. So patient experience, it's everything.
Yeah.
So if the patient has a great experience, great, they're gonna come back. They may go to another office, but they will be back, definitely. It
That's
happened
right.
to me.
That's
Some
right.
patients say, I'm not gonna come back. And then after a while, I say, no, doctor, yeah, I like you better. I like your staff. I know it's more expensive, but I don't care because you guys treat me as I want to be treated.
That's
So
right.
that's the best compliment for a patient anyways.
When we completely agree, and this is the reflection of that, when we treat people well, our new patient tracker, this column is taken care of. It's the biggest number you see anywhere. 143 patients. So, they're averaging 14 new patients a month, single doctor practice that has resigned from almost all of their insurance plans except for insurance plan D. That's the last one left. And they're getting great referrals. Why? Because people really, really like them. I did a example with a doctor because we looked at what was he writing off for insurance, and we said, okay, insurance is costing you $200,000, and how many patients has it sent you? Fire that marketing company. How much are you paying for Google? All right, that's a healthier number. What are you paying per patient to get them in the door? So a little bit of a joke, but when you look at it, you go, wow, why would I be in network with insurance to get more new patients? Well, that's not why people are choosing me. They're choosing me because they love us. They love how we treat them. And that's exactly what Dr. Pierce is referring to. Yeah.
So
Good stuff.
you were quicker. I was going to say that word of mouth. It doesn't matter
Yeah.
if you're a specialist or not. They may not come back to the same service, but they will refer you other patients. And that's priceless. It's free.
Yes, it is free marketing. It just takes energy and time, and there's a system for that. I say, Larissa, Dr. Paris and I were talking this morning. We both acknowledged we really love seeing in our practice. You are just such a great friend for us. In fact, we were talking about how, to be selfish, we'd love to have more patients just like you. We have a great relationship, and so I want you to know we appreciate you, but I'm also wondering if you will be willing to help us out. And most people love to help. I'm curious, would you be willing to recommend us to your friends, family, and coworkers? Is that something you're comfortable with? And she says, yes, great. If she says, no, I don't talk religion, politics, and dental, then move on to something else. Talk about a review or something else. But if she says, oh yeah, I would, great. Here's our referral cards. I would love to give some to you. And we really, really appreciate it. And then every time she sends someone to us, she happens to get an Amazon gift card in the mail. $25. And Pavlov's dog, she looks at it and goes, oh my gosh, you mean every time I send someone to Dr. Pierce, I get a $25 gift card from Amazon? Sure. And if she's already great, she's not a stick in the mud, then awesome. I'm going to get more great patients. Birds of a feather flock together. So we have a system for everything that puts insulators in place. That's why it's not just hey, let me give you this verbiage. Are all of these things overdue hygiene? Do you know how to work that system? Message one, conversation one. Are you using the verbiage to get them in? Do you have a system for calling them? Is your marketing working? Are your new patient flow right? Is your case acceptance verbal skills excellent? Because you can't just be telling people, well, you need a crown, and then wonder, well, wait a second. That's not going to work. It's got to be on a whole different level for this. So there's a lot of things that go into play. And our goal, our hope is that more and more offices move in this direction because it's healthier for the solo practice. We want the solo practice to survive, the family practitioner. And you probably all kind of know what I'm talking about here. I've got a great relationship with DSOs that I work with, but it's hard to compete with that. And so you got to have everything, all your ducks in a row if you're going to compete with that, because I think that is something that's on the front, the horizon for us to think about. And there's great DSOs and there's not so great ones. So, in fact, if you own 2 practices, you're a DSO by definition. Dr. Pierce. All right. Thank you guys so much. Email us, connect with us. We're here to support you. If you have questions, I'm happy to answer it. anytime. Larissa and I would be happy to jump on the phone or Zoom with you if you have questions. Heather at allstardentalacademy.com. She would love to talk with you guys about things. I think we do a pretty good job. We're working with over 100 clients right now in our coaching division. So yeah, if anybody wants to stay around, happy to do that. We'll stop the recording and we'll dive in a little bit more. Thanks, guys.
Thank you.